I'm Bennett, broadcasting from Miami, Florida. Tonight we have another in the series of Parkinsonism educational hangouts with Dr. Abdul Rana, neurologist from Toronto and world-renowned medical educator. Tonight, Dr. Rana is going to be talking about polyneuropathy in Parkinsonism, a relatively new field, he tells me. Welcome, Dr. Rana.
Thank you, Dr. Bennett. How are you this evening?
Okay, very good. Let me start off with a question first. What are the general features of polyneuropathy?
The polyneuropathies are usually a distal phenomenon, and they usually start, in most cases, with sensory symptoms. In case of Parkinson's disease, the recognition of polyneuropathies is relatively a new field. In case of polyneuropathies, it could involve the axons of the nerves or the myelin sheaths of the nerves. And usually it involves mostly small fibers first, which convey touch and pain and temperature. And then with time, they could involve the large fibers, which carry sense of vibration. So these patients in the beginning may have sensory symptoms such as numbness, tingling, or paresthesias, and they usually involve feet or toes first, and then it could progress with time and may involve upper extremities or hands. And these patients may develop a distal type of weakness with time as the condition progresses. The assessment of these patients does require a detailed exam, such as motor testing, sensory examination, as well as reflex testing. And these patients overall would have a glove stocking pattern of sensory loss, like affecting their feet as well as their hands first.
What are the common causes of neuropathy?
Neuropathies could be due to many diverse causes. Most of the causes are metabolic or endocrine, and one of the common cause is diabetes mellitus, otherwise uremia and thyroid problem, various types of infections or toxic causes, nutritional deficiencies, or relation with previous treatment with chemotherapy or exposure to toxins, alcohol, sometimes the genetic causes such as in Charcot-Marie-Tooth disease. Among the nutritional deficiencies, B6, B12, and thiamine deficiencies could be important causes in these patients. Some of the cases of polyneuropathy may remain undiagnosed in terms of the cause. So they are idiopathic or cryptogenic polyneuropathies. About 40 to 50% of cases in elderly patients could still remain undiagnosed in spite of extensive serological investigations. You can't find any cause. So in these cases, most people think that the polyneuropathies are related to age.
Okay. How is polyneuropathy related to Parkinson's?
In case of Parkinson's disease, the sensory symptoms like the numbness, tingling, or paresthesias, they were more recognized in 1970s or so, around that time. And at that time, it was noticed that about half of idiopathic Parkinson's disease patients, they had these sensory symptoms, and about less than 10% or around that number, these sensory symptoms could start before the classic motor symptoms of Parkinson's disease. It was noticed that the sensory symptoms were occurring more in the off periods, like if these patients were on levodopa and the effect of medication would wear off, then these patients would get numbness and tingling or paresthesias. So most of the researchers or scholars thought that this was related to central dopaminergic deficit, because this was correlated with the dopamine wearing off. So when electrophysiological studies were done, in some cases, they failed to show any significant abnormalities. So that endorsed that thinking of these sensory symptoms being a central phenomenon. So at that time, the scholars were thinking that it could be due to the dysfunction of basal ganglia and related pathways, and the wearing off periods have a significant role in these patients, that they would feel these symptoms, especially in those times. And indeed, because of this thinking for a significant period of time, there was a relatively lack of any studies to assess the involvement of the peripheral nervous system in case of idiopathic Parkinson's disease. The clinical and electrophysiological studies do suggest that about 90% of patients could have elevated methylmalonic acid in their serum. Now, these patients may have an axonal form of polyneuropathy, and the reason for elevated methylmalonic acid is not known. But if you compare these patients with sensory symptoms and idiopathic Parkinson's disease with those patients who have idiopathic, who have otherwise idiopathic polyneuropathy, then there is elevation of the methylmalonic acid in a significant number of these patients. However, if you test B12 level, so they may not be significantly abnormal in most of these patients. So that leaves in a dilemma that what is the exact mechanism of this phenomenon. Because when there is a B12 deficiency, then it leads to elevated homocysteine as well as methylmalonic acid levels. But further work has shown that there is a relation of severity of polyneuropathy, peripheral polyneuropathy in these patients with Parkinson's disease with the lifetime use of levodopa. So if their overall use of levodopa is more, so their degree of peripheral polyneuropathy is more severe. And also, if you look at their daily levodopa equivalent dose, that also seems to correlate with the sensory findings of polyneuropathy. And some work has been done in which they looked at using the intestinal gel form of levodopa, and then it does correlate with the impairment of the peripheral nervous system in these patients. In addition, the severity of peripheral polyneuropathy is also correlated with elevation of fasting levels of methylmalonic acid. Although the B12 deficiency, the cobalamin deficiency, is more related to or more known to cause subacute combined degeneration as well as bilopathy, but the exclusive presentation of peripheral polyneuropathy in B12 also occurs, and that is usually axonal form of polyneuropathy. The cobalamin deficiencies otherwise in idiopathic polyneuropathies is only seen in about 5 to 10% of the patients. The measurement of serum methylmalonic acid as compared to B12 is more specific as well as sensitive. And most of the experts are recommending to check homocysteine and methylmalonic acid as compared to just looking at the B12 levels, because they may not be grossly abnormal in these patients. The levodopa catabolism itself, when you take levodopa and levodopa catabolism, it itself causes elevation of serum homocysteine and methylmalonic acid in patients, and the decrease in cobalamin, which occur in idiopathic Parkinson's disease patients who would have a higher intake of levodopa. So identification of such patients had helped to the study of a relation of levodopa dose as well as the elevation of homocysteine and methylmalonic acid levels in these patients. There is a correlation of polyneuropathies with the severity of the symptoms of Parkinson's disease, as well as the longer duration of Parkinson's disease, and overall cumulative dose of levodopa in these patients. So the greater severity of disease is correlated with the greater severity of polyneuropathy in these patients. Although still the precise mechanism that how methylmalonic acid causes the nerve damage still remains to be studied and is unknown. Some experts do think that there could be deposition of alpha-synuclein protein, and it could exert some neurotoxic properties in the peripheral nerves, and that could be a cause of polyneuropathy in these patients. Therefore, as I said, I think a lot of work needs to be done to study the relation of B12, homocysteine, methylmalonic acid to the peripheral neuropathy, which still remains unclear.
Very good. The last question. What can be the consequences of polyneuropathy?
Polyneuropathy could, when it coexists with Parkinson's disease, it could lead to several problems. In patients in which symptoms of Parkinson's disease are very mild and they are presenting in the initial stages, if they have peripheral polyneuropathy due to any other causes, and if these patients don't have a tremor, it might become a bit difficult to assess, because these patients may have gait and balance problems, and because they're elderly, so it becomes difficult to assess how much is the contribution of polyneuropathy in their gait and balance problems, and how much contribution or role is played by Parkinson's disease. And so these patients, when they have polyneuropathy with Parkinson's disease, so their gait worsens, their balance worsens, that leads to falls, and these patients are prone to injuries because they have lack of sensation in their feet, as well as they can't perceive the information from their joints and the lower part of the body. So that leads to difficulties maintaining their balance, and they feel unsteady. So falls and balance issues become a major problem in these patients. And as you know, the falls are a very major problem in such population, and they could lead to fractures and hospitalization. And then once the patients are hospitalized, it has its own complications. So I think if patients are suspected to have peripheral polyneuropathy with Parkinson's disease, it should be assessed in a timely fashion, so that if there are any other contributory and reversible causes, such as thyroid or B12 deficiency or infections, at least these things could be treated, and that would lead to improvement in the quality of life of these patients.
Okay, very good. That wraps up the questions. Is there anything else you'd like to add before we go?
I think it's a new field, and the studies are coming to our knowledge. Myself, being a student of movement disorder, Parkinson's disease, and neurology, I'm myself learning this field. So I think we need to do more work to see if we can have some of the prophylactic interventions, such as if we can treat these patients with the B12 from before they develop the polyneuropathy, so that their balance in gait is not affected, or their polyneuropathies, the process of development is slowed down. I think a lot of research need to be done in this field, and as as we move on, hopefully we would get more data, and neuromuscular experts would also hopefully consider assessing the Parkinson's disease patients in their large clinical studies, and that could bring to light many aspects of this field which still remain unstudied.
Okay, very good. We look forward to hearing more about developments in polyneuropathy of Parkinsonism. Thank you, Dr. Rana, tonight. And this video will be able to be seen on Parkinsonism.tv. Good night, Dr. Rana.
Thank you, Dr. Bennett. Good night.